Well, hello, everybody, and thank you very much, Rebecca, and thanks to you all for attending. It's a huge pleasure and privilege to be invited this afternoon to talk to you. So as Rebecca has told you, my talk to you today will be a little bit about the science behind debridement with larval therapy, but we'll also talk a little bit about the background of maggots and why on earth do we use larvae in wounds. Okay, so it'd be great if you have any questions. I'll be very happy to answer them at the end. I think Rebecca's told you how to sort that out. So today's day is about debridement. We all know that if you have a chronic wound, it's really important to debride it, to get rid of the devitalized and dead tissue. And the reason for doing that is because that tissue acts as a physical barrier, and you won't get progression through the normal stages of healing of a wound if you've got loads of dead and unwanted tissue sitting there. Of course, there's another reason, and that if the wound isn't already infected, and we know that most chronic wounds are, in order to reduce the risk of infection, because the tissue itself is a fantastic source of nutrients for bacteria and other microbes, then it's really important to eliminate it. And you've got to reduce the inflammatory response, as you know, because that's the key hindrance to progression to wound healing. So debridement is absolutely vital. You know that to enable the management and the debridement of chronic wounds is an absolute huge abundance of treatments, of dressings, of debridement options, and so on. But the one that we're going to talk about today is known worldwide as maggot therapy. It's known obviously in the UK as larval debridement therapy or larval therapy or maggot debridement therapy, and also it's been called biological therapy too. But across the world, the consensus is to call it maggot therapy. Well, what exactly is larval therapy? It's the clinical application of teeny tiny living, growing maggots. They are the babies, if you like, the larval stages of the green bottlefly, Lucilia serracata. The larvae are also known as medicinal maggots, and they are able to debride and cleanse wounds. Firstly, let's talk about the evidence that we have that supports the debridement, the effective debridement of wounds by larvae. Now, the clinical evidence that we have has accumulated over the last 30 years. It was sort of late 80s, early 90s that maggots became used in the UK. And we know that our evidence comes from numerous controlled studies, loads of systematic reviews, retrospective studies where they've used larval therapy and then realized, wow, this was brilliant. Let's put up some case studies about it. Case studies, of course, you know about anecdotal evidence, but of course our gold evidence, the gold standard is randomized control trials. That's a level 1 evidence. So do we have any RCTs that look at larval therapy and debridement? And actually, yes, we do. Randomized control trials are wonderful because they're carried out with hundreds of patients, so they give you a really accurate idea, obviously, of how things work. And the 3 classic ones, the quite large ones that have been undertaken recently, have all concluded that larvae were the more effective in wound debridement than any other comparative treatments. And in fact, very recently in 2021, Green et al. Have published a systematic review of venous leg ulcers and maggot therapy. And they've shown that larval debridement was found, they concluded it was found to debride venous ulcers at a very fast and very effective rate, but in fact, it actually debrided wounds at a faster rate than hydrogel, had a very similar effect to sharp debridement, which you probably know if a patient is capable of having sharp debridement undertaken, it's obviously one of the quickest ways to do it. But if larval therapy comes in a close second there, it was also concluded it was a very resource effective method of debridement. And in fact, when larval therapy was used in combination with compression therapy, rather than compared to compression alone, larvae had a greater effect on debridement. And that's literally just come out, this paper in 2021. So the first question to ask ourselves is, well, why do larvae debride wounds? What's in it for them? And in order to understand that, we're going to very quickly go through the life cycle of the medicinal maggot. So this little creature, this larva, has been crawling Earth for around 250 million years. That's a long time. We as humans have only been around for about 200,000 years. So they've actually been around for ages. This is the mother fly, the green bottle, as I said, Lucilia sericata. That's her Latin name. It's really important. That's the species we use. We don't use any other species of fly for clinical larval therapy. Here's a picture of the male and the female. Males, as is the case with many species, are a bit redundant. They don't do an awful lot in terms of the biological progression of the species. They're only really good for one thing, and they do that with great gusto, leaving a pregnant female to lay her eggs. And the pregnant female, each fly is capable of laying something like 200 eggs per lay, and she will lay several times in her life, and in total is capable then of laying about 2,000 to 3,000 eggs in her lifetime. And that's just one green bottle female fly. But she's such a caring little mother fly that she will want to lay her eggs very close to a food source, so that as soon as her little hatchlings, her little baby larvae emerge, they have food straight away. Okay, in my lab, and I've got a research lab where I rear maggots and larvae for research, not for clinical use. We grow them on liver, and you can see the flies have laid their eggs on liver. The eggs are very much like tiny little grains of rice at this point, and they can hatch within about 1 to 2 days, depending on temperature. And the tiny little maggots that hatch are called L1s, right? L1 stage. They're literally about 1 millimeter to 2 millimeters in length, very, very small. And their main job in their whole life is now to start feeding. And they begin to feed quite crazily, and they'll feed for about 3 to 5 days. And at that point, having molted once to become an L2, they will then molt again to become the L3 stage. And this is about a centimeter and a half. And that's more like the maggot size most people associate maggots with. So that's the L1 stage, and that's the L3 stage. At that point, having reached its maximum growth as a larva, the L3 will oval itself up, become a little bit short and fat. It's now ready to become the pupa, and the pupa is encased in a hard little shell, and inside that shell the adult fly is growing. Could be a male, could be a female, but it's developing in there, and that takes about a week to complete the development. So that pupa will now emerge as a fly after about a week. And it's quite important because clinically a lot of people worry, will I have flies coming off me if you put the maggots on a wound? Will they come off as flies? Well, they won't. And one of the main reasons they won't, A, is because we remove them after 4 to 5, even 7 days. You can remove the L3s. They're still fat L3s. 1 or 2 might have started to pupate, but remember, they will need at least a week in there before they can even begin to emerge as flies. And they don't like a wound environment to pupate in. They like dry environments, not moist environments. In nature, in the wild, what do the larvae of Lucilia feed on? Well, you've probably seen dead pigeons or dead rats in the garden, which very soon will have maggots swarming on them. And if I show you a picture of this elephant that's died naturally in an African jungle, you'll probably be able to notice, if I show you the next picture, that within 2 days, it's swarming with maggots. So flies have been attracted, they're intensely attracted to the smell of death. They arrive and they'll lay their eggs. Maggots will hatch out, and there they'll start to feed. And within 2 weeks, those maggots have stripped that flesh down to the bone. So they're very, very good at eating dead flesh. In fact, maggots are nature's speediest eliminators of dead tissue, nature's most speediest debriders, if you like. So why do maggots do this so quickly? If you are a tiny, tiny little L1 maggot or L2 maggot, both are very, very small, it's in your best interest to very quickly find a way to eat and digest really fast so that you can get bigger and bigger. When you get to that big stage, you are now a really juicy morsel, and you're being predated on by beetles, by turtles, by birds, all of which love your fat, juicy body. So it's really, really important that you very quickly move through your larval development and get to the adult stage where nobody really wants to eat you because you're prickly and you're feather, you have wings, and you're not really very tasty at all. So larvae have evolved for their own survival to become very, very fast debriders, very rapidly feeding on dead tissue. So that's the life cycle, okay? But who decided that we could put larvae in wounds and it would have a beneficial effect? Well, if you look at the history, you'll realize that maggots in wounds are actually mentioned in the Bible. In the Old Testament, there's a part which talks about the beneficial effect of maggots in wounds. And then we know from historical data that ancient tribes and cultures like the Nigam Aborigines, for example, used maggots to help heal their wounds. And in fact, the Central American Mayan Indian tribe used to take white pieces of cloth and dip them in ox blood, hang them out to the sun, so that very soon that would attract flies who would lay their eggs. And when that material was swarming with maggots, they would then use it to put onto wounds and festering wounds and so on. So all these historical records show us that maggots have been around for a long time. But what about more modern times? Well, in 1829, we have a written document from Baron Dominic Jean Larry, who was Napoleon's battlefield surgeon, and he noted that in the field, soldiers were becoming wounded and they were being covered in maggots, but they were healing and the wounds were not festering or anything. And it wasn't until about 100 years later that Dr. William Baer, who's an American surgeon, he's actually believed to be the pioneer of maggot therapy. He was also a doctor serving with the American forces in France in 1917, and he witnessed soldiers with swarming maggots in their wounds. But he noted they were apyrexic, there was no fever, and there was no infection. And so he let the maggots stay in the wounds. And when he got back to his hospital, he started to rear clinical grade maggots. And so he introduced sterile maggots into his patients who had wounds in the early 1930s. They were hugely successful. And by the end of the 30s, 300 hospitals in America and Canada were using maggots to treat patients, some with chronic osteomyelitis. So they were being treated for very, very severe wounds. And then this wonderful guy came along. Most of you will recognize him as Alexander Fleming, Scottish scientist who discovered one of the most, I suppose, the most amazing discoveries of a whole lifetime, which was penicillin. And so in the 40s, penicillin became industrially produced, and maggot therapy, when it was being used for infected wounds, declined completely. Okay. However, it was only 4 years after the industrial release of penicillin that we found the first resistant strains of Staph aureus. Now, throughout the last 60, 80 years, people have tried very hard to combat resistance, and we've lost that battle. We are losing that battle, as you probably know. Resistance, isn't it? We're on the verge of this global catastrophe. Okay. So for that reason, being one of the reasons, there's been a remarkable re-emergence of maggot therapy. There's been a renewed interest in maggots. It's been approved by the FDA in the States and in many other countries, and it's available in the UK on NHS prescription, I think, since 2004. So we really have grasped it and said, right, it's one of our major things that we can use in wounds. It's used clearly for the cleansing and healing of infected necrotic chronic wounds. And so much so that sterile commercial grade larvae are available worldwide in many countries, not all. I get people writing several times to say, why don't we have it in Saudi Arabia? And why can't we have it here? And it all depends. Obviously, UK, Germany, BioMonde, I think, have send it to many countries in Europe. And remember, they're clinical grade. Be careful, which maggots can be used clinically for larval therapy? It's only of that Lucilla sericata species, and we don't just pull it out of some sewage or some poo and start using them. They're actually very, very specially reared, okay? So these green bottlefly larvae have to be reared under strict, aseptic, very clean conditions. And you can see here how they're organized in very, very neat cages, but also how strict people are about working with them. The flies themselves are really super duper clean, and the eggs are sterilized and washed before they go on to hatch into these tiny little larvae, which are fed on a non-liver diet, and they're fed on this cereal based added protein diet, and they grow very nicely, and then they're sent out clinically packed as they are at that stage, tiny little things in bags. The bag has in it a little foam, like everyone thinks it's a sugar cube, it's not. It's a tiny little foam piece, so that as the larvae grow, they don't the bag doesn't collapse and on them and might suffocate them because there's so many larvae. So it does have a little foam spacer. But the larvae will arrive in their bag, sealed in a little Eppendorf tube, a universal tube, and you can just take them out and apply them with forceps or whatever. Okay, now to how do larvae debride wounds? Okay, we know that they're really fast, but what clinical and scientific evidence do we have of the effectiveness of larval debridement? I'm going to show you a few case studies first, and I'll start with when maggots were available free range from Princess of Wales. It was before BioMonde came on the scene, and this was a case study of one of my colleagues, Steve Thomas, who worked there, and he said he told us there was a 76-year-old lady who had a very long-standing leg ulcer filled with this viscous slough, and it had been dressed by community nursing staff for over a year and a half, using all sorts of dressings, trying to promote autolytic debridement, but that had been completely unsuccessful. So they asked the lady if she would put on a single application of free-range maggots, and she was very, very reluctant. But they said, well, if you put that on, we can take it off as soon as, if you come back and you don't want them, we can take them off. So she agreed, and they put them on, but she came back 2 days later and said, I can feel them. I don't like the feeling. Can you please take them off? And when they took it off, they found that the whole slough had gone, the necrotic tissue had gone, and you can see healthy granulation tissue had formed. And even the lady was absolutely stunned because she'd been living with that infection and that wound for a very long time. But the wound was now free of slough and of course, the newly formed granulation tissue you can see under that. I was actually in podiatry when this lady was brought into podiatry. She was very frail. She didn't know she had a necrotic heel, she had a necrotic toe. She was a lady with diabetes too. She was in her 80s. She was considered too frail for surgery. They wanted to amputate the big toe. But Ross, who was a podiatrist at the time, suggested maggot therapy, and Ross loved free range, and the lady agreed. So they put free range maggots on her toe, and you can see them tucking in right there. The wound bled a little, and you mustn't ever be worried about that, unless of course your patient is contraindicated with bleeding disorders. But the bleeding is very much a part of what the maggot does. The maggot secretes an anticoag called sericase, which we know works to help cleanse the wound out, and of course the toe was saved and went on to be healed. So it debrided and got rid of all the necrosis really well. I'll show you this as well, because this was following an amputation of a big toe in another patient with diabetes. You can see that the amputation site became necrotic and the patient was scheduled for further amputation, but a maggot bag was put onto the wound. Look at how it was 3 days later when you take it off. You can barely see the larvae when you put the bag on, but when you take it off, you can tell that not only have those larvae grown, but they've taken the necrosis, the infection, everything with them. It's one of the reasons why it's very you carefully have to incinerate and get rid of the bag afterwards. But you can see how clean they left the wound after 3 days. So that's clinical evidence. There's loads more I could bore you with, but I won't. I will move on now to quickly tell you a little bit about what we know about the science and how do maggots debride a wound. This particular species, Lucilia sericata, feed exclusively on dead tissue. It's another thing that you need to reassure your patients about, and I'm going to come more to that and explain that in a moment to you. They're selective for dead tissue, but they have no teeth. Okay, so if you ever see that, that's really wrong. Larvae do not have teeth. So how do they feed? They do, by the way, have mouth hooks, and you can see a picture here with 2 mouth hooks. The mouth hooks are literally only there to help the maggots attach, so they're attached to things, to substrates like the wound. And as they move, those little hooks help in mechanical rasping to help to break down the tissue, but they are not teeth. So larvae have no teeth. How do they feed? From inside the bag. That always amazes people. Well, the way that they do it is they secrete a juice, a digestive juice, and that juice comes out of them, some from the saliva, some from the body. It all contributes, and it passes through the net bag. Okay, and that juice, which does contain digestive enzymes, but contains loads of other antimicrobial factors and things as well, that juice digests and liquefies the dead tissue, and they can then drink that back up through the net. Right, so that's how it's possible, absolutely possible, for larvae to feed through the net. So scientifically, we've analysed what's in this juice, and it's been discovered that maggots produce a powerful array of enzymes for the digestion of their food, which in our case is the wound. What are enzymes? Well, they're like chemical scissors. They snip bonds between long molecules of protein, and they cut them in small bits so that the amino acids are formed, and they can then drink that up because it's nice and liquefied and tiny little molecules for the maggots to take up. The two main enzymes that have been identified from this cocktail of maggot proteases are enzymes that digest protein, and the two main ones are chymotrypsin and trypsin, and that's what they look like. If you really wanted to know, they're very similar in structure. They allow for the rapid and efficient degradation of necrotic tissue. In my lab, when we put larvae on liver, you can see this frothy exudate. That's the juice. And that frothiness contains the very powerful mix of enzymes that we know helps to digest the wound bed. Very recently, in 2016, they discovered a new larval protease. Poppel et al., some German researchers, have reported the presence of a very active protein digesting enzyme that they've called Jonah-M. And this enzyme, they believe, is key in wound debridement. It works best at pH 8, which we know the maggot provides, and it works well at 37 degrees, which is human body temperature. It digests many extracellular matrix proteins, so it's got a phenomenal range of digestion. Excuse me. So larvae possess several different enzymes which play a vital role in wound debridement. Very recently, a colleague of mine, David Pritchard in Nottingham University, decided to artificially create the larval chymotrypsin enzyme, and that's called a recombinant. So he made it artificially, okay? And what he did then was he took some venous leg ulcer slough that you can see here, and he ran it on a gel, and the gel separates out the proteins that are present in that slough. And then he also took some of the same slough and he added the recombinant chymotrypsin to it. And then he ran that on a gel to see what the difference was. And what he saw when he looked at the untouched venous leg ulcer eschar tissue, the slough, he found many, many proteins, big fat proteins in it, which were going to stop wound healing, which were going to inhibit all sorts of good healing molecules in that wound. So he knew that the slough wouldn't go anywhere until these proteins had been removed. And when he tested the gel of his recombinant enzyme with the wound eschar, he found most of the proteins had disappeared and only 2 or 3 were left, which made it much easier for that wound now to progress to healing. So chymotrypsin does degrade an awful lot of proteins that you need out of the way before that wound can progress to healing. Okay, so larval chymotrypsin is the key enzyme that digests the venous leg ulcer slough. Why is it such a good enzyme? Why is it so effective? Right, well, you know, in a wound, you've got your own endogenous enzyme inhibitors. They sit there alongside the wound proteases, but they sit there to inhibit. They actually tend to break down a lot of autolytic enzymes that we produce, because that's part of the balance, the control mechanism between enzymes and enzyme inhibitors in a wound. So maggot chymotrypsin doesn't get inhibited by these enzymes. Okay, and this is again David's work. He's tested it and he's shown that the wound enzymes can't inhibit maggot chymotrypsin, and that actually will explain why larvae debride a wound where other enzyme interventions or even autolytic debridement have failed because of the inhibitors that don't happen to be able to touch maggot chymotrypsin. However, when David was doing this work, he discovered that there was one protease inhibitor that actually did inhibit maggot chymotrypsin. He was really quite upset about it. So he discovered that this inhibitor was called alpha-2 macroglobulin. And don't worry about the name, but he wanted to find out, well, this actually inhibits the maggot enzyme, but where do we find alpha-2 macroglobulin? And it turns out that you only find it in healthy human tissue. Okay, so that possibly explains why larvae cannot eat healthy living tissue, that they will eat dead tissue, and other studies have shown that they will starve if you put them on healthy living tissue. So again, it's a really good point to note, to take away, to tell patients that these larvae of Bacillus auricata can eat dead tissue. They're inhibited by alpha-2 macroglobulin, which probably explains why they can't eat healthy living tissue. Okay, I've got 3 minutes left. I'm going to finish off with a case study, which actually just highlights the speed of debridement by larvae. And I'm going to come back to this case study if you're around for the wound healing talk that I'm giving, I think, in November or December. This was a case of a 78-year-old man who had critical limb ischemia. Okay, he had lots and lots of ulcers, and they had tried so many things, but because of the ischemia, his poor circulation, he wasn't healing very, very well. He had severe ulcers with exposed bone on his right foot, and you can see that the ulcers were numerous, and quite a lot were present. And in Japan, like I guess they probably wouldn't treat as conservatively as we do. They performed a transmetatarsal amputation, and they took off all his toes. Well, the wound that was left dehisced 2 months later, and you can see how it had become infected and necrotic, and they were planning further and further amputation. Somebody in the surgical team suggested using larvae, okay? They put them on, free range in this case, they put them on, and this was 2 days later, 2 days after initial maggot placement. Look how clean that is. That's unbelievable. And of course, that went on to heal a couple of months later. That was absolutely fine. But I will come back to this because there's a really interesting wound healing aspect to this case study as well. So to summarize, we have speedy debriders. Our larvae are superb at debriding. Remember, they have no teeth. Yes, these gorgeous little mouth hooks, but they can't bite. They can't feed with teeth. They secrete powerful enzymes to rapidly and efficiently debride necrotic tissue. But I leave you with a question. Can larvae help with other things like wound disinfection or wound healing? To find out, join me next time when BioMonde Live talks about disinfection of wounds with larvae.